Hello. Our next session topic is called the benefits of a multidisciplinary team. It's so important to feel comfortable and have the right doctors with you along this journey. So today we have a rock star panel, the best of the best. We have a researcher and oncologist, Dr. Ross Camidge, researcher and oncologist, Dr. Vicent Lamb, radiation oncologist, Dr. Drew Maghanaki, thoracic surgeon, Dr. Brendon Stiles, and palliative care doctor, Dr. Laura Petrilo. Thank you all so much for joining us, and we're so glad that you're here. And I'm not sure if you all are all on Twitter for all of the attendees, but I encourage you to follow all of these doctors because they're all quite vocal. Sometimes I can't tell if Dr. Maghanaki and Dr. Stiles are fighting or joking. Well, let's start with Dr. Camidge. Dr. Camidge, can you start and tell us what is a multidisciplinary team?
Well, I mean, literally, it means people from different therapeutic or diagnostic disciplines working together. I think it is, to some extent, these have existed in kind of silos and people have sort of pulled in different people. But I think what it's starting to mean is they're all on the same team at the same time and involved in making the appropriate decisions for one patient.
Now, can a multidisciplinary team change?
Well, sure. So if you like, they're all like the players sitting in the dressing room, and for the individual patient, you may say, well, what we really need is Brendon and Drew, and you don't need Vicent or me. And so you pick the members of the team that are needed for that patient.
Perfect. Dr. Lamb, what is a tumor board? Is it different from a multidisciplinary team?
Yeah, it's semantically different, but in some multidisciplinary teams actually operate with a specific meeting in which they incorporate a tumor board. But a tumor board is really a gathering in which we discuss specifics of a patient case often with multidisciplinary team members to really try to identify the best course of action for that patient.
When does a patient's case go to a tumor board?
Ideally, most of our cases should be going to tumor board at some point in the patient's journey. But oftentimes, because these tumor boards usually entail input from multidisciplinary members, oftentimes these tumor board cases are brought up for patients who are actually locally advanced or localized stage. But more and more so, we're having tumor board discussions for patients who are stage 4.
And can a well-informed patient be a part of a tumor board?
I think that's a great concept. I am not aware of any tumor boards personally that incorporates a sort of patient attendance. But many multidisciplinary teams have, a setup such that the patients see different members of the multidisciplinary team and then, meet with each of these physicians after the tumor board or multidisciplinary discussion.
Amanda, on that point, if I can, I don't know if I'm allowed to jump in, but
absolutely.
But I think sometimes people think the tumor board is, this star chamber where someone is talking about their case behind their back, and that's both true and untrue. I mean, we may be talking about 30 people in a tumor board, so it's hard to have that one person there just for their case. And then to kind of jump on what Vicent said in terms of who goes, I tend to present new patients or difficult, situations. But one of the things I'd like to kind of throw out, and maybe we can see what the others think, is at the end of the day, I do believe there's one physician who's actually responsible for that patient. and it's not a way of removing responsibility to kind of group think. So I at least in the tumor board which I chair, the presenting physician is the one responsible for capturing that information and putting it in the medical note. We don't have somebody who issues, this is the tumor board's opinion, and therefore, I'm removed from responsibility. But I don't know how it works at the other sites.
I'm sorry.
No, I was just going to say I'll chime in and agree with Ross. I think that's a great point, and I think it's it's hard in the theoretical area of the tumor board to really understand the patient in front of you, and a lot of ALK patients probably know that, right? The individual patient might be very different from something that you can see and imagine on paper, and that can sometimes be challenging to convey. Of course, you'd like to have the patient there, but for practical reasons, it's challenging. And often it's a place for really experimentation and throwing out ideas that, although we might not suggest, hey, we should definitely do this, it's something to sort of have in the physician's back pocket and something to think about. When you think about multidisciplinary, I think we often used to just think that this was the stage 3 patient or somebody who needs all those disciplines involved in the care, but increasingly we're seeing stage 4 patients who might have local treatment options, stage 1 patients who we think may be candidates for adjuvant or neoadjuvant therapy presented at tumor board, and I think that will continue to expand. It just becomes a challenge with all the patients being presented and how to manage the time.
Would you consider the oncologist kind of as the patient's captain of their ship, so to speak?
Well, it depends. I think each patient may have a different captain. It depends really where they come from, who brings that patient to the tumor ward. And, sometimes it's a pulmonologist, sometimes an oncologist, sometimes a radiation oncologist, sometimes a surgeon. I do think it's important, though, that each patient has a champion at tumor board to sort of advocate for that patient.
Amanda, I think one more thing to add is sometimes the tumor board is a lot more people that the patient would never see along their journey. So here at UCLA, when a patient is queued up to meet all of us, and we're now doing it with Zoom in a morning session, one patient sitting on their couch can talk to 3 or 4 different specialists. But the hour before we get going, we have a tumor board where about 25 people are on, and these include radiologists and pathologists. And there's a lot of uncertainties in what we're doing. We're trying to figure out what the scan means. We're trying to understand what the biopsy means. Do we need to get it in their biopsy? And so we're basically consulting all of our advisors at once, all in the same room, which is a lot better form of communication than emails and paging and waiting for someone to call you back. So really the tumor board is a way for all of us to get on the same page. That way we can make the messaging as simple as possible when the patient's in front of us.
Just to bring this back to multidisciplinary team, I'll say the tumor board is a moment in time where everybody's in the same room and having a conversation and a dialogue. And then I think about the multidisciplinary team being kind of the ongoing longitudinal care of the patient and family and how we're working together across disciplines. And that often does involve emails and paging and communicating in the medical chart. But it's also kind of not always synchronous in time. Sometimes we're having different touch points with patients and kind of, I think one thing to just acknowledge too is that multidisciplinary teams, and this is brought up about tumor boards too, frequently occur kind of organically in academic medical centers. They certainly can happen too in community oncology practices, but just to name that, there are very likely different experiences and different things that people have access to in terms of multidisciplinary teams, depending on where people receive their care.
Perfect. Let's talk about consolidation. Drew, what is consolidation and what does that really mean, and what is your role?
Yeah, it's interesting. There's definitely various new vocabulary that patients have to learn. I think Jill Feldman describes this perfectly as once you're diagnosed with lung cancer, it's like you're basically entering a new country with a new language and people and the culture. And the words, sometimes can be confusing because we as doctors, we try so hard to simplify our messaging, but it's very hard for us to downshift from, the super high intellectual, vocabulary. And so there's different words like adjuvant, neoadjuvant, consolidation. We even use the word salvage sometimes, palliative, et cetera. But consolidation specifically kind of means, in a way, like a cleanup, secondary treatment. So the definitive treatment is the treatment that we think can possibly eradicate all the disease. And whatever that first definitive treatment might be, either surgery, radiation, or chemotherapy, there might be a consolidation kind of come on the back end for like a secondary boost to see if we can really clean up and eradicate everything. That's my understanding of the word consolidation.
Great. And can you explain your role as a radiation oncologist, and what are the different types of radiation that are offered?
Yeah, so radiation is used, the machines that are installed in radiation centers around the country or the world have a clearance to be aimed at people for all sorts of conditions. So how we use it, we have to be very careful about it. Radiation is very precise. It can often eradicate what it's aiming at, but it can also, sometimes not be helpful for people. And it can also cause tissue injury. So radiation delivers a very focused dose of high energy of usually photons, sometimes with protons. So photons are just X-rays. And it basically inflicts a wound on what it aims at. So it inflicts a wound on the cancer, and sometimes that's sufficient to get rid of it all, sometimes not. And it can also inflict a wound on the normal tissue around it. So depending on the course of a patient's journey, from the first diagnosis to later on having spread and just needing some pain relief, there's various different roles, and happy to talk about, describe each side. But it's very complicated. Our colleagues in surgical and medical oncology often try to describe radiation therapy to the best of their ability, but it's usually best for a patient to, if radiation might be a possibility, to make the time, sit down, talk with one of us. I'm aware a lot of times a medical oncologist will say, hey, you should go talk to the radiation oncologist, and the patient just doesn't feel like sitting down. They ask the medical oncologist, who they know are more familiar with, to describe it. And I feel that often the patient will end up short on knowledge about what it may be able to offer them.
That's great. You provided some slides. Do you mind if we show them?
Sure. I was asked whether or not we wanted to make any slides, and if you want to go ahead and display those. I think when it comes to patients with ALK, we don't commonly aim for complete tumor eradication. It might be using it for metastatic lesions. And I have two slides. And the first one, I just wanted to show all these big names. There seems to be an arms race between the industries that are making these different machines. And so you may hear the standard machine is at the top left, called a TrueBeam, which is made by one company. There's other companies make similar ones, but they're basically generic linear accelerators, delivers highly focused, minimally invasive treatment. They're usually inside of a large concrete bunker. And the patients, one of the kind of best parts about radiation is you don't really feel it when it's happening, and you can drive yourself to treatment and go home. And so that's basically what it looks like. On the right is this robotic machine. So the patient's laying there, and the patient's dead actually sometimes can move around, and the robotic can move around like a scene out of the movie Aliens, and it aims from different angles. And then you may have heard of a gamma knife in the bottom left. This was the first machine that was used to treat very small tumors in the brain for brain metastases. Now, any of these machines can actually do that. So you may hear about that machine, but it's unclear anymore whether that machine offers any advantage over the others for radiosurgery for brain metastases. And on the bottom right, this is the most recent FDA-approved device that I'm aware of. This machine, actually, the patient lays on this kind of flat bed and slides into there, and then this lead canister kind of seals around them, and they're inside this capsule. And the capsule is completely shielded, so this device can be installed anywhere. It can be installed in a lobby of a hospital. There's no concrete bunker required for it, and someone just sits at that console, and they can zap little. And the design, it was actually designed by a world famous neurosurgeon out of Stanford, John Adler, and who actually designed the CyberKnife above, and now ZapX is the second one. And there's not that many of them installed in the world yet, but just to say that there's different devices, but the key thing is knowing when to use it and how to use it. And so on the next slide, for patients who may eventually develop brain metastasis, and I'll never forget at the last conference in Atlanta, we had this raffle, right, for patients to go to the soccer game. And on the way back, two of the people who I had hosted were just talking with each other saying, oh yeah, so when were you diagnosed? What treatment have you gotten so far? And one of them asked the other, have you had brain metastases yet? And I'm just thinking, that's not a normal conversation for two people to have. But I guess if you have stage 4 cancer, that's something that you need to be aware of. So that's what inspired this slide here. So often when patients develop brain metastases, in the old days, we used to just treat the whole brain just to be safe. But today with MRIs, we can typically know how many brain metastases are in there, and we don't need to treat the whole brain. So we use radiosurgery on the top right and just treat 1 or 2 or sometimes up to 15, 20 spots and try to not treat the whole brain. And this really helps with preserving memory. Short-term memory loss is one of the biggest side effects of whole brain radiation, so we try to avoid it. Now, in the bottom panel, there's 3 pictures. This is the same patient where there's just too many lesions to do radiosurgery to all of them. So we really want to bathe the entire brain with a low dose of radiation, and then we can kind of heat up, see where those areas are red. Those are little hotter spots of boosted radiation. And then we discovered the 2 most important, or I guess the one most important memory site in the brain called the hippocampus. And I don't understand the math or the computer science behind this, but basically the radiation beams can somehow hollow out those areas to really reduce the possibility of injury to the memory. And then and these have been studied in a randomized trial and are showing a definite reduction in memory loss. And then on the right, also, there's now a medication that we prescribe patients who are getting whole brain radiation to try to preserve as much of their brain function as possible. Most patients who get brain radiation don't have substantial memory loss, but some do. And so these are various techniques that we use to try to avoid that from happening.
Those are great, thanks. Dr. Brendon Stiles, you are known as this great surgeon that kind of will take, I don't want to say take a risk, you think outside of the box because a lot of people go to you, lung cancer patients. So my question is, when does surgery come into play for a lung cancer patient?
Yeah, well, I don't know that I think outside the box, but I think of each patient on an individual basis. And I think that's probably the most important take-home lesson of all this. I think surgery, obviously for early stage disease, plays a critical role. And I've operated on several stage 1 ALK patients, and we think that we've cured them. It depends upon our stage, and obviously depends a little bit upon luck, but those patients do well. It's about 2% of our surgical patients. And it gets more tricky, I think, and probably what you're asking for most of the attendees is this idea of local consolidation therapy for patients with metastatic disease. And there's a lot out there about oligometastasis, and a term that means just a handful of metastasis. It can mean 1 to 5. It can mean sometimes more than that. It's a complicated space. But I think, and I'm interested to hear what all the others think about this, that if you think about young active patients with lung cancer, which is what many in the ALK community are, that if we think that there may be a role for local consolidative therapy, that we should consider that option. And the idea is for patients with limited metastases with what's called oligoprogression, meaning that all the other sites are responding, maybe one site is progressing. What should we do? What should we consider? There's different types of oligoresistance, other things, but as many of you know, many patients or most patients will develop resistance to these amazing drugs that we have. And so I think there is some attraction to the idea of treating a local site so that you might not get persistence or resistance at that site. That can be done either with radiation therapy or surgery. Obviously, the tenet there is to do no harm. The last thing I want to do is knock the patient out of the possibility to get on another trial for systemic disease, which is really probably what's going to extend their life more. There's been a handful of trials, though, in this oligometastatic space, one by a guy, Dan Gomez and MD Anderson, another by Puneeth Iyengar, and then a SABRE comment, which covered a lot of different tumors that suggested that local treatment in metastatic patients might make a difference, at least in progression-free survival. That makes sense, though. Obviously, you're treating one site with local therapy, you're going to be less likely to progress there. But they also showed some signals to advantages in overall survival. And I think that particularly might make sense. And the authors really argued that that might make sense for patients in which effective systemic therapies exist, right? And so those were patients who got treated systemically first, and then they just had sort of single site or few site disease and then got treated. For me, a classic example is single brain metastasis in a lung tumor without nodal disease. We might resect that. I saw a patient recently who was being considered who had great response initially to alectinib, but then had growth of a left upper lobe tumor in a pretty wide distribution. I thought that would be challenging to radiate to know that we got it all. It was amenable to lobectomy. All her other sites were controlled, and so she'd had metastatic disease prior, but we did a lobectomy on her. And you can balance the risks of that with radiation. I think for each individual patient, you really should. I don't think we should be out there sort of treating every patient or thinking every patient or every site of progression needs local therapy, but I think it's a space that's continuing to evolve. And I think it can be used interchangeably with radiation. One just needs to weigh the risks and balances of both.
So understanding that type of having surgery is not a perfect fit for every lung cancer patient, how do we get more cancer or more surgeons to look at each ALK patient as a personalized treatment plan versus just the stage of their cancer?
Well, I think that's a tough question. I think ideally each of those patients would be seeing an expert medical oncologist who is well versed in ALK and who can sort of help us select the appropriate patients for surgery. I think that, and the same holds true of selecting patients for radiation therapy. I think, there's lots of surgeons out there throughout the country who I think know how to do these operations well and are willing to do them. It's the idea of sort of the oncologist identifying the appropriate patients for that type of therapy and sort of getting their input and really talking about it in a multidisciplinary setting.
Amanda, can I ask Brendon a question here? So,
Yes.
traditional surgical thinking is, you don't want to leave anything behind. Whereas when you're doing in the stage 4 setting, there's stuff left behind. So do you do a different operation than if you were taking out like a primary? I mean, are you more likely to do a wedge resection rather than a lobectomy, for example?
Yeah, that's a great question. I mean, I guess it depends on the individual situation where you see the disease progressing. I think, if I'm trying to do for the primary tumor, I would still favor lobectomy just because we know that there's a high chance of regional disease. And I think the idea of if you're going to be there, it obviously depends on the morbidity of the patient. If they just had a single peripheral lesion that's growing and everything else was controlled, that patient I might consider doing a wedge for. But I think, like increasingly even in early stage disease, we're tailoring the surgery to the patient and to the tumor, and that tenet should probably hold for metastatic patients as well.
Dr. Petrilo, I think that your role is just as important, if not most important. Not only do we want to think about quantity of life, but quality of life. When I was first diagnosed, I was referred to a palliative care doctor, and I did not want to go because I thought end of life, end of life hospice situation, which is actually not the case at all. So can you help everyone understand what is a palliative care doctor and what is your role?
Absolutely. Thanks for sharing your experience about that. It's so common to feel that way. So, and hopefully we'll debunk a lot of that today. So palliative care is a medical specialty that's focused on helping people with the symptoms and stress of serious illness like cancer. So we help with physical symptoms like pain, shortness of breath, nausea, side effects of treatment. And we also help with psychological symptoms like dealing with the distress of a new diagnosis or a change in cancer kind of trajectory. And we support caregivers. We think about patients, their caregivers, their families as a unit of care. And so we're really trying to provide comprehensive care in that way. And we think of ourselves as an extra layer of support and another member of the care team. So working closely with oncologists, radiation oncologists, social workers, just everyone kind of coming together to provide support to patients. Palliative care, just to name, is appropriate for any age and any stage of cancer. And I'll just dive for a moment into the history and kind of differentiate from hospice, because just to name it and just say that's often on people's minds. So once upon a time, I think initially the idea of kind of focusing on quality of life, it was sort of an either or of focusing on quantity of life and extending life versus focusing on quality of life. And you focused on quality of life when there weren't options for focusing on quantity of life and extending life. And the idea of hospice care sort of arose sometime during the last century of kind of having this specific place where people could receive their end-of-life care. And the hospice medical benefit was in the 1980s, and it really forces people to make a choice between receiving cancer-directed therapy in this case, or kind of this comfort-focused, quality of life-focused therapy. About a little over a decade ago, people started to really think of palliative care, the whole kind of medical field of focusing on quality of life, as a giant spectrum, and thought about this kind of along the disease trajectory, thinking about layering it, as I was mentioning, on top of oncology-focused care, so that we're not waiting until someone doesn't have the cancer treatment options, but actually thinking about treating people for quality of life right alongside their cancer-directed care to improve quality of life while people are going through treatment. And this idea was tested in a randomized controlled trial that was published in 2010. in patients with advanced lung cancer to randomize people either to get this kind of early palliative care. And in that case, it was integrated with care at the time of diagnosis. So patients meeting with palliative care doctors to learn how are your symptoms going, kind of get to know the palliative care team. We palliative care doctors and nurses were working closely with the oncology teams. And in that study, patients who had palliative care integrated with their care had better quality of life kind of throughout the course of their illness compared to patients who were in the randomized controlled trial arm who didn't have palliative care integrated in their care. They knew more about what to expect, felt kind of better prepared for things as they came along. They had better coping. Ultimately, when patients were at the end of life, they had less kind of dying in the hospital and kind of healthcare utilization, and more people were at home and had kind of experiences that were consistent with what they were hoping for. And in that particular study, this was a secondary question that they asked. They wanted to make sure kind of there's always this concern. If you start to focus on quality of life and treating pain and symptoms, is that going to take anything away from the cancer-directed care? So they looked at survival in these two groups just to ensure that people who were receiving quality of life focused care weren't living any less long. And in fact, in that study, and part of the reason it just was heard all around the world, was that the patients receiving early palliative care lived longer, which has been seen in a few other studies. And certainly we don't lead with that. We lead with quality of life. That is what we are there to do. But just know that it is something that is intended to be an extra layer of support for people, helping with quality of life and symptoms. And I will say too that just oftentimes people like me who train in palliative care, we also train in hospice medicine. So that sometimes, my title will say hospice and palliative care, and there's still plenty of stigma and expectation that these terms are synonymous and exchangeable. So somebody might say, I'm seeing my palliative care doctor, and their friend might say, oh my gosh, what does that mean? And I always tell my patients, it doesn't mean I don't have any extra information besides what you already know about what's going on with your cancer. I'm just here to help. And kind of, it's different for every patient what we focus on, whether it's symptoms, physical symptoms, psychological symptoms, illness understanding, coping, you name it. There are many different things that we focus on. And somebody asked a question, and sorry, I know I'm talking for a long time, but just about there. Somebody asked a question about how to advocate for palliative care. Ask. Most medical centers do have palliative care. There's much more inpatient palliative care than there is outpatient palliative care at the moment, but outpatient palliative care is growing. If you go to www.getpalliativecare.org, and I can put that in the chat, you can find if there's a palliative care clinic near you, because the kind of stigma and misconceptions exist not only among patients and families, but also among clinicians. And it's just, we're a young field, we're growing. And so all of you now know, and when you hear kind of things that are not correct, you can correct people.
So
Amanda, if I may,
yes.
I just wanted to highlight that Dr. Petrilo has actually done a lot of the seminal work in palliative care for TKI specific patients, specific to TKIs, because, traditionally we've really gotten used to incorporating palliative care into the journey for cancer patients, in large part due to the study that she mentioned. But I must admit, I think there's a little bit more reticence or, just less familiarity with incorporating palliative care in patients on TKI, for example, who, for example, in ALK, we have a highly effective therapy in which its overall survival is pushing 8 years and getting longer. But it's important to note that, based on Dr. Petrilo's research, there's a lot of value in incorporating palliative care in helping manage TKI side effects and other issues that are maybe more specific to our, generally younger patient population. So it's really great that we're highlighting that here.
Hey, Amanda, may I ask a question to Laura too? You mentioned the stigma, and I do think it's real though. When somebody gets referred for palliative care, right, then others may say, oh, I'm going to withhold treatment. It's not so much our community, but I feel like other doctors in the hospital or residents or med students may somehow treat that patient differently. How do you message that to the other treating teams at the hospital?
Yeah, absolutely. I think the things that really are on our side are evidence. I mean, I think evidence is always so helpful in communicating with our colleagues, and anecdotal evidence. So if clinicians have had a patient who has benefited from palliative care, then they're much more likely to refer. And, you know, I feel so fortunate to be at MGH, where really so much of the research has been done, and also our oncology colleagues just know what we do and respect and refer to us in such a way. But even in my own institution, there's still a misunderstanding. So there's so much campaign right now to sort of increase awareness about palliative care, and I think just continuing to talk about it. I will say it probably comes up from time to time about the idea of even just changing the name. And in our field, we still sort of hang on to with what our history is and who we are and how we're trained. But I have heard kind of increasingly, and personally do sometimes use the term supportive care, and did work in a clinic called the Symptom Management Service Clinic, just because there's a lower kind of barrier to entry when we're talking about it in that way. But I think leading with what we do is really the key for convincing people. And then once people have experienced it, either learning about it from a friend or family member, or as a clinician learning it from a mutual patient, hopefully those are the most convincing things.
Can I throw something in? Because I threw this out in some of the emails before the meeting that, for an international audience, I think the real strength of the Mass General studies that Laura and others have been involved with is taking on, the horrors of the American medical system, which force people to make a choice between active therapy and palliative care. And that's a uniquely US problem. In many other countries, and you kind of touched on it, the hospice and palliative care movement was developed, nearly a century ago. They originally grew by separating themselves from, the evil clutches of the therapeutic doctors, but always with the goal to reintegrate. And that reintegration happened in many countries in Europe and in other countries around the world, where there was never an issue as that you could overlay these things. And so I think on the one hand, I was slightly flippant in my email saying, duh, but this is working in the US. But, that's the problem. You have to deal with the environment you're in and personalize the solution.
Yeah, thanks.
I would love to add a comment to that as well. Laura, your work is amazing. And I really do believe that the messaging is the problem. I've actually been colleagues with Tom Smith at Hopkins for many years about this. I fervently believe that the name needs to be changed. You can't change public perception. It's just too big of an ask. It's going to take generations. What I do is I kind of use like a common sense approach to bring people down off the ledge when they have the fear about, I don't want to go to palliative care. I don't want to go to the end of life. I'm going to go into the fight for life. I'm going to stay in the fight for life game. And I just say, look, we are cancer experts, and these nice people in that section, they're symptom and supportive care experts. I can sit here and spend a lot of time trying to manage your symptoms, but I have other patients to see and I have to focus on my craft. And, it's the same for surgeons and medical oncologists. We will deliver the treatments and do the best that we can to manage your symptoms. Would it be nice to have someone who would really focus on your symptoms? For me, every single time the patient has been so happy to learn that would be the case. And so it requires a little, I think, self-effacement and humility for us to say, look, I'm not a symptom expert. I can masquerade like I am, but those are really the experts. And so I wonder so maybe ask a question. What do you think the probabilities are of the society considering re-messaging, rebranding?
I don't know. I think it's interesting. And I wanted to also just belatedly say thanks to Dr. Lamb for mentioning our research around this. And I also want to thank a lot of the people who I imagine are in the audience who actually participated in some of our qualitative studies to understand the supportive care needs of patients living with oncogene-driven lung cancer. Because our research is actually in the phase of, we have kind of been descriptive about the issues related to supportive care for living with lung cancer and receiving a TKI. And we're actually at the beginnings of developing a supportive care intervention, and we'll be testing it in a randomized controlled trial, hopefully within the next couple of years, like NCI pending. But then in designing palliative care and supportive care for patients with lung cancer with targetable mutations, what we actually started to think about was incorporating some elements of survivorship. So the concept of survivorship is usually thought about in kind of early stage patients who have completed definitive therapy, and thinking about surveillance, kind of living a healthy lifestyle, exercise, care coordination, all of these things that are usually creating a survivorship care plan. And there's really a movement, and I think Dr. Smith, as you mentioned, is one of the people really advocating for this, to think about kind of advanced cancer survivorship and think, especially in this era of people living longer. So I could see this kind of concept of a blended supportive care model that has elements of palliative care and has elements of survivorship. And, we always talk about, our people think of us as focused on helping people die well, and we think of ourselves as focused on helping people live well. And I think survivorship is a word that really gets that message about living well. And so I'm not sure, to answer your question, how likely it is that will change, but I do think it is, possible in the near future.
So, Dr. Petrilo, do you feel, and you've kind of touched on this too, as soon as someone is diagnosed, or we've all been diagnosed here, should they be getting a palliative care doctor right away? Or let's say someone gets on lorlatinib, and there's some people that have a lot of side effects from those. Is that when they choose to go to see a palliative care doctor, or should they just have them in their back pocket at all times?
So I think once that seminal study came out in 2010, actually within a few years, it actually became ASCO guidelines and kind of really supposed to be the standard of care, that palliative care is integrated in oncology care from the time of diagnosis. And I think part of what inspired me to do this work is actually that I felt like we were starting to go in the direction of drifting back towards being incorporated later because of novel therapies, just because of so much optimism and hope and wonderful results too. I mean, people doing well. And yet I'm still kind of back around after thinking about it a while. Do we figure out like a staged model and come in at various times? I'm back to still thinking that integration early is important. First of all, for adjusting to a new diagnosis, whether you have symptoms or side effects or not. Second of all, for just learning the team, we're better able to help. Like when I have a day full of my patients who I've known for a long time, it's a totally different clinic day. We're able to just jump right in and have a totally different conversation. And we like to be, and I heard mention about kind of going to 6-month scans and the wonderful story that we just heard. We can go to 6-month visits. I mean, just kind of maintain contact with people. We don't have to be all up in people's business if they don't need us, but having that rapport early and relationship, I think is really important. And there are many things that sort of set the stage for living really well with cancer. And I think those are journeys that people take on their own to find the peer support and the resources. But I think, thinking about quality of life and brainstorming together early, I think can only help.
And I will raise a slight warning though, because not everybody's got a LoRa, right? And so it really does, you can see some of the comments in the chat are saying, boy, at our hospital system, you can't even tell what it is on their online thing. And so you do have to be careful. There's a lot of great oncologists like Vicent and Ross who are really good at managing side effects, and particularly early on. And so I think the decision should be individualized. I think you should definitely think about it early. And I think when you have the appropriate people in place, it's good to do. But I do sometimes worry about that early stigma of going to a group, particularly if they're not as experienced as Laura's group is.
Yeah, and it's interesting, and I think it's important to say, well, so that the standard of care is once the patient starts really declining, that's when they get palliative care involved, really usually near the end of life. And I think that's why people think about palliative care as end of life specialists. And the stigma and the concerns and stigma are actually that Dr. Stiles brings up were exactly the motivators that drove the randomized trial, because we're talking about usual care when you really need it at the end of life versus started early when you're still walkie-talkie doing okay. But yes, that is a very important caveat, because that trial was done at a very advanced medical center. And so if there's a palliative care team, I wouldn't just kind of fling a patient into the community to some palliative care doc somewhere who I don't know. I would really want to be sure that they are a part of the team and actually part of the multidisciplinary team.
Well, I will push back actually on that a little bit. So I do think the thing that we are trained to do is listen. before we talk. So we ask a lot of questions. We get to know people, we get to know what their issues are. And so we are not forcing an end of life or hospice conversation the first time that we meet someone, or even at any point if it's not something that seems aligned with what they need from us. So I think while our early integrated palliative care is specialized to MGH, I will emphasize again, the ASCO guidelines is to integrate palliative care early from the time of diagnosis for all patients with advanced cancer, not just ALK-positive lung cancer, not just lung cancer, all advanced cancer. And I think we are early, we're a young field, and we are still all learning. And, a lot of us are involved in educational efforts just to make sure that we're up to speed. And I'm often, to be honest, trying to be a realist about the potential benefits of some novel therapies to my palliative care and geriatrician and primary care colleagues, because sometimes they'll be like, oh, another MAB and MIB, and what is this, and what is it really going to do for my patients? And often I'm like, you know what, the best quality of life focused care is going to be getting this patient on therapy. And I'm pushing for, just to make sure that somebody has an effective cancer-directed care, and really debunking that for my colleagues. So I think that there's a lot of education going on within our field to try and stay up to speed, but we're not experts, which is why we're a team.
I mean, one of the things, if I can jump in here, so for some of you may know that I trained in Britain, and then when I came to the USA in 2005, I remember sort of phoning up saying, okay, so I've got this patient with pain, where's the palliative care team? And they went, well, we have an inpatient palliative care team, but we don't have an outpatient. And so it's taken about, it took about 7 years to get an outpatient palliative care team. And that for me is key. It's almost like Drew's point here, to have someone like Laura sitting in the clinic, not that far away from where I am, so we can go and knock on each other's door. In my clinic this week, I went around to the palliative care room, 3 times for different patients. And I think that's the ideal model where you're treating a person, what's going on in their life, we had this conversation with someone who their goal was to get to their birthday and their daughter's birthday, which was in the same month. And then they didn't care what happened after that. And when you know that, you can be much more focused in terms of your goals.
Perfect. And I don't want to keep going back to you, Dr. Petrilo, but one hot topic that's very often talked about is anxiety. Anxiety for scanxiety right before your scans. And just in general, everyone kind of goes through this journey on their own sometimes. And sometimes you just have some anxiety about this disease and about yourself. Is that something that you specifically help with?
Absolutely. I think there are, so I will agree with you 100% that anxiety or distress related to cancer is a big deal. And it also, I think, sometimes I'll encounter people who don't necessarily want to bring it up because they feel like their scans are looking so great, and they don't necessarily want to share or talk about the ways that they're struggling or the distress that they're feeling. And I think that, central to quality of life is being in a good kind of mental health spot. So I think there are a variety of different ways to manage kind of that distress and anxiety. And I think, first, usually it's figuring out sort of how much it's affecting someone's life. And so that sort of dictates a little bit about what kind of path we take in terms of managing it, because it could range from working together to talk about coping strategies and figuring out which coping strategies somebody has used in other times in their life, and what things they might, what muscles they might grow in the course of dealing with cancer. And then thinking also about other kind of multidisciplinary team members, such as a social worker, therapist, psychologist, to involve in someone's care for something like cognitive behavioral therapy or other kind of supportive psychotherapy. And then we also think about medications. So I'd say it runs the gamut in how we manage anxiety, but that certainly is within the palliative care wheelhouse, working within a team, and is super important. And if you're dealing with it, please talk with your clinicians.
Great. We have a lot of questions, so we're going to try to get through some of these. Let's see. A lot of palliative care. One thing I do want to ask is when an outpatient has progressed on their TKI and they have to get a needle biopsy, and then a bunch of outpatients, their needle biopsy comes back. And as we all know, waiting for those genetic testing results sometimes takes and seems like it's forever. And when they get the results back, it was a bad pool or an inconclusive. And then you want to make sure that you have a pathologist that is in the room to do a needle biopsy to make sure that his slide is good. Is that up to the oncologist to double check to make sure that the pathologist is there to help with the needle biopsy, or is that up to how do we make sure that we get a good biopsy once you've progressed to make sure for your next steps?
That's a great question. I'll jump in first and we can see what the oncology folks say. I think, we as surgeons are often tissue procurers, but we're often involved in decisions to send patients to pulmonologists or for needle biopsies. And I do think that when you know the stakes are high, it's important to have processes in place that you know in real time that you're getting tissue. And in the OR, if you're doing EBIS, people call that sort of rapid on-site evaluation. In general, at our old program, the pathologists were right there beside the people doing the CT biopsy, and they'd say, yes, we have enough tissue. You really have to think about it beforehand, though, and it becomes lost in the medical record sometimes. If you just send a patient for a biopsy, people don't know that you're looking for specific moleculars, and they may get less tissue. So we really do count on everybody who's touching lung cancer to identify those patients early and to really make sure that the biopsy person knows we need tissue.
Perfect.
I mean, my take, though, is you don't request rapid on-site evaluation when you request the biopsy. There are institutions who happen to have that in place and others that don't. I mean, Brendon, is that your take, or do you?
No, exactly. I think the important take home there, if you have it, it's great. And if they can tell you real time that you're in the lesion and you have enough to think you have enough tissue, then I think that's definitely an add-on. I think if you don't, it's really just important to specify that you want enough tissue for molecular testing, just so that they can hopefully work around that. It doesn't always get you out of the situation that you described, but at least in our hands, it makes them sort of work a little harder to make sure they get tissue.
And to your question, Amanda, I think maybe it's helpful to know that I'm not aware that the patient has a role in requesting this, because there are institutional standard operating procedures, and some facilities may have the rapid on-site capabilities, and others may not. But if you go to a place that does this often, I think that helps, because, for instance, our pulmonologists, I forget the statistic, but they're pretty used to the indication for their procedure is to obtain tissue for molecular profiling, almost approaching 50% or something like that. So they know that the quality of the tissue is super important. So they have these these things in place to ensure that. Perfect.
And here's a question from Mark. Do you follow up with radiation after surgery, brain and neck dissection?
Yeah, I think I was actually just seeing that. That's a very complicated question that would be best addressed with a formal evaluation. It requires a careful review of the pathology report and actually the next level of kind of attention to that is also a direct conversation with the surgeon. So cases like this are often presented in multidisciplinary tumor boards, where we have the pathologist in the room looking at the slides with the surgeon and the radiation oncologist. And then there's different algorithms that we use to decide whether or not to give radiation. We generally don't want to give anyone radiation who doesn't need it or is going to benefit from it. So I think it's difficult to provide a generic answer to that question.
Perfect. If you have had a lobectomy and radiation to the remaining bronchial trunk, what options do you have with progression in the same area, since you cannot radiate it in the same location?
Oh, I've never seen that. Brendon, have you?
Well, that's a tough one. I mean, the question, I guess, is whether the radiation to the bronchus was for a positive margin or whether this was adjuvant radiation because of positive nodes. I think Drew will tell you, and the radiation oncologists have gotten increasingly better at getting back and re-radiating, particularly focal areas if they don't have to do a wide field. Sometimes those situations, if we see recurrence after surgery and radiation, and there's nothing anywhere else, that's one of those unique situations that we could sometimes discuss a reoperation for as well. But I think it's a very, very individualized treatment plan that needs to be developed there.
Yeah, and unfortunately, the bronchial stump, if it's already been kind of devascularized by surgery and then devascularized further by radiation to that area, more radiation to that area could cause a permanent fistula. It would be very difficult to manage. So that's a very tough case. And that's the kind of case that I would only send. That deserves a multidisciplinary review and a tumor board review at a tertiary academic center.
How long should you be, and I'm going to botch this, how long should you be on Momentine?
Momentine.
How is it? What is it called, Dr.?
Momentine.
Well,
That's
it
a
sounds
question
better
for,
when,
that's a question for Drew.
I was going to say, it sounds better when you say, how long should you be on Momentine after radiation to the brain?
It's interesting. I haven't given whole brain radiation in so long. I always have to go back and look up the reference. So I can kind of search the internet while we're talking.
I think it's 6 months, isn't it, Drew? Is it 6 months or a year? I can't remember.
I would just follow whatever the trial used, and you could argue maybe you should be on it longer. For those who don't know, it's a drug that's used for Alzheimer's memory preservation. And so those patients take it for even longer. But at the end of the day, when the randomized trials are done, they have to fix the time period. But yeah, if you think 6 months sounds about right.
Maybe you could take that stash that you had in the picture, Drew. I had to get one shot. I had to get one shot in
terms of joined up thinking. It's not uncommon for the radiation oncologist to prescribe it with the patient not appreciating how long they need to be on it or no management of side effects. It's kind of like, here's some pills, off you go, guys.
Yes, that's true.
Linda,
so Vincent and I usually have to tidy that one up.
Exactly. I was gonna sort of just also highlight another thing, along those lines, which is just the use of radiation to the brain, for our patients. It's interesting that Drew mentioned that, he hasn't given whole brain radiation in a long time because we actually don't need to give whole brain radiation as much anymore. So, in the era of highly effective targeted therapy, it's really nice that we're able to have these CNS penetrant drugs, and so that really, I think, emphasizes the importance of a multidisciplinary team that can really discuss each individual specifics for each case.
Yeah, the last whole brain I considered was a person with over 30 metastases in their brain, and it was quite a gripping conversation. And thank the Lord, the next line of therapy eradicated it all from the next scans.
Do it's funny, just to sort of nerd out just for a second, Amanda, but we've gone through this move where we've started to say, okay, we want to try and educate people to give the TKI and tell Drew to kind of back off for a while. But if you think about the kind of stories that Brendon was talking about in terms of, well, we don't wait for progression, maybe you consolidate, maybe we're going to bring radiation back in earlier when we put them on the TKI, they haven't progressed, but maybe there's still some residual stuff. So the concept of consolidation in the brain may come back in. It's not just about eliminating radiation. But I don't know what Drew thinks about that.
Well, I like to use the word mileage to think about how local consolidation therapies with surgery or radiation should be thought about. So what do I mean by that? Well, unfortunately, it's a time in history, we don't have that many lines of therapy. So if you're on first line therapy, if that doesn't work, so that's usually, you go with something that was recently FDA approved. That doesn't work, you have to go to the second line therapy that was approved 5 years ago. And if that doesn't work, you're now using something that was approved in the early 2000s, and then you go to something that was approved in the 1980s. So you're going down a hill of lesser and lesser effective therapies. So wouldn't it be great to keep the person on the best line of therapy for as long as possible? Well, what happens is, let's say a patient has, 8 to 15 metastatic lesions at diagnoses, and all of them disappear except for 1 or 2 lesions, maybe 3. And those other lesions are being controlled by the drug is working. What's happened is that the tumor has mutated, as Dr. Brendon, were you going to show your slide with David Palma by chance?
Sure, Amanda, if you want to put it up.
That was a great slide for this kind of conversation where you have different types of cancers now in the body. So what if we could get rid of those pesky cancers that are not controlled with surgery or radiation? And I think earlier on is kind of a point of investigation right now. And then you can get more mileage out of the drug that's working. So that's one way to think about local consolidation therapy. Right?
Yeah, and this is just a slide, I think, that's interesting discussion points from David Palma, who's really been a leader in the space of treatment of oligometastatic disease and led the Sabre Comet trial. He's a radiation oncologist in Canada. This is for a paper that we worked on together. And really it illustrates the heterogeneity really of progression and of presentation, right? And you might have few metastasis, and whether they're synchronous, meaning they show up at the same time, or the metastasis comes up a little bit later after treatment. Progression at just one site, everything else goes away and you have persistence at one site. resistance at one site. Nothing is one site is really growing. These are complex things to think about, and really there's no way to systematically look at them. We just don't have enough patients to really get real data at that. So I thought I would love to hear just, people ask me all the time, but it really, as I mentioned, I'm interested to hear what Vicent or Ross think about which patients they think are really appropriate for either radiation or surgery if they have sort of one of these situations arise.
Vicent, do you want to throw something out?
Sure. I mean, I guess, taking a small step back, what we're trying to do is to try to make decisions and trying to balance in terms of consolidation. This is what Dr. Stiles is asking about, and trying to make decisions to try to balance potential benefit for increasing, patients' overall survival with the potential risks of each of these modalities, whether it's surgery and or radiation or maybe even chemotherapy as part of this. But the underlying premise for all this is, unfortunately, the TKIs, as good as they are, don't eradicate tumor in a stage 4 setting, don't completely take it all away. So this is a super area, a super active area of investigation to try to figure out how best to get rid of these persister cells, and surgery, radiation, various drug approaches. I think those should all be considered really for maybe, all our stage 4 patients, at least be a conversation. Ross, I don't know if what your heuristics are.
I agree. I mean, it's funny because I don't know if I've told Drew this, but I started off as a radiation oncologist, and then I realized I wasn't smart enough, and I had to become a medical oncologist. And so I kind of have some sympathy for the use of radiation. And then Brendon, I should tell you, I faint at the sight of blood, so I was never going to be a surgeon. So what happens is the idea of oligoprogression, zapping things or resecting things, I think is maturing. I think that the field initially started with kind of like, well, you had one residual site or something like that. And then like anything else, we then pushed the envelope. And, I think the natural move from that to kind of what you had in your slide is oligopersistence. Why wait for the progression to occur if there's just one thing left? Either zap it or cut it out. If you cut it out, then we actually get tissue to study this persistent state. So that's kind of exciting, but it depends on where it's located. So I'm kind of, we all evolve in our thinking. I'm moving more towards that consolidation approach. Mostly it's radiation in our practice, more than surgery. But I think even when I started thinking about the brain mets, I was chatting to my colleague Chad Rustoven, who's one of our radiation oncologists here, and he sort of very politely said, well, great, you have these CNS active TKIs, but how long do you control it for? And you go, well, a year or something. Goes, well, but if I give it SRS, maybe that totally takes it off the table. So the idea of bringing in consolidation even for the brain, I think maybe our next wave. So it's not radiation bad. I don't.
Perfect. I wish we had more time. This has been a great panel. Thank you all so very much for your time and your help. I think this also is a great reminder that communication is key within a multidisciplinary team. And I do have one question to ask you all, whether it's professional or personal. What does stronger together mean to you? So I know we all can't answer, but somebody pop in and tell us what you think.
I think that here you've seen the kind of how a multidisciplinary team can be stronger together, but I do want to point out that kind of patients, caregivers joined together with oncology teams and research is stronger together. So I know you have your kind of patient community that is stronger together, but I would say across kind of clinicians, patients, caregivers, advocates, we're all stronger together. So it's just, this has been such an exciting area to be in because of how empowered everyone is and active and passionate.
Great. Anybody else?
I just have to think that neither of us can do this alone, and operating in vacuums and silos is not the right way. I mean, it is just a no-brainer that pulling everyone together, including patients, to help us better understand how to deliver care, whether if it's for cure or for symptom management, to help people live longer. I think that we're without a doubt, we're stronger by having input from everyone.
Yeah, I mean, I love these kind of interactions. I love being educated by my colleagues, and including by the patients who, you know, who can search the internet much more than I do. And that's the fun of it. And that's how we move things forward.
That's great. Well, thank you all so very much for your time. I wish we had more time. We are almost out of time. Please tune in. We have a short break. Our next session is with Dr. Camidge again and Dr. Christine Lovely with what's next after lorlatinib, TKIs and beyond. Thank you all so very much. Take a break and we will be back in about 15 minutes.